So today we're reviewing heart failure in the new heart failure guidelines. Um, this is one I think even more so than other pieces affects both nephrology and cardiology because of the diuretics and the limitations we have on GFR. I'm sorry, the limitations that GFR places on initiating therapies in the heart failure space. So, can get quite problematic. But as we go through this, just recognize that the heart failure guidelines have now come out in 23 with two I believe at least one update, one on HFpEF, but I think there was another one as well as an expert consensus decision pathway. So, of course, faculty disclosures, here I am. And then here are the learning objectives for today. Really just looking at the implications of the heart failure staging and classification recommendations. They did update this, and it's very similar to how atrial fibrillation, actually it came before atrial fibrillation, but I think the guidelines across the board are really looking at stages, and that includes like pre-heart failure, pre-AFib, pre-ASCVD, etc. And then summarizing the pharmacologic treatment. So hopefully you get more comfortable with what's being used in the heart failure side, but really y'all are most likely prescribing some of these as well. And then how to titrate and initiate some of these things, especially SGLT2s. But again, I think nephrology is doing a great job and have been ahead of the curve, probably on SGLT2s and certainly with like non-steroidal MRAs. But let's kind of think about this a little bit in terms of questions to ask yourself about heart failure. So according to the TREAD-HF trial, now, you may or may not have heard of the TREAD-HF trial. It's a great time to go back and look at it. One of the slides will have the citation for it. But what should be done when a patient's LVEF improves from 35% to 50% while on GDMT? So A, increase the patient's SGLT2 inhibitor to twice a day. B, decrease the patient's beta blocker dose. C, discontinue therapy as the patient has achieved their goal, whatever that means. And then D, nothing, continue current therapy. So I'll give you kind of a second to think about that and what you would do. But I'll go ahead and give you the answer as well, which is really nothing, continue current therapy. And we'll talk about this, but recognize that heart failure is not an EF percent, really. It's a cascade of disease that's occurring. And so even if the EF improves, it doesn't mean that you've solved the problem of what's going on with disease itself. Yeah, great. Yeah, Kimberly got it. And so I'll keep the chat open so I'm paying attention to that too. Pre-survey 2. So a patient with an LVEF of 55% and HFpEF, heart failure preserved ejection fraction, takes furosemide at home. Which of the following would be the most appropriate agent to add to the patient's regimen? So A, empagliflozin, B, isosorbide hydralazine, C, losartan, or D, sacubitril valsartan, otherwise known as Entresto. So, I mean, if you feel brave, you can answer in the chat, as Kimberly has done. And then I'll go ahead and give us the answer here, which is empagliflozin. And we'll talk about the rationale later on as we go through this. So a 67-year-old patient with no past medical history is admitted for a newly diagnosed HFrEF. You're like, wait, how did a 67-year-old get through with no past medical history? Okay, newly diagnosed HFrEF. Which of the following GDMT strategies will provide the greatest mortality benefit? Greatest mortality benefit. A, ensuring PCP follow-up within 1 week of discharge to initiate GDMT. B, ensuring adequate supply of diuretics at discharge to manage volume. C, initiating an ARNI and titrating to maximum effect prior to discharge. Or D, initiating all 4 GDMT agents at maximally tolerated doses. So I'll give you a second here to kind of think through that a little bit, and then I'll go ahead and provide the answer here. So initiating all 4 GDMT agents at maximally tolerated doses. Okay, so something to just kind of think about on your own. How often do you currently ensure that patients with HFrEF, I know we all see them, are initiated on all 4 GDMT agents? And we'll discuss what those agents are, if you're not familiar or have not heard of them. So just kind of think about this, because we all see these patients. And who owns that, right? The answer is the patient in front of us owns that, and we need to help facilitate best practice. So updated heart failure nomenclature. And this is where we'll kind of get into the staging. At risk and pre-heart failure are kind of new pieces to the nomenclature. Really, part of this is shifting to a chronic disease model, recognizing that it's not really a one and done thing. It's not like acute and then never again. So we rely on a staging system, recognizing that it's a lifetime kind of component that we're looking for, because it is a common disease that all of us will be treating. So anyways, heart failure is a chronic disease. Even in the absence of symptoms, there are activation of neurohormones, negative remodeling of the ventricle can occur. So really, again, that HFIMPREF or whatever, the improved ejection fraction, those people, they're still in this activation of neurohormones. So just because EF improves doesn't necessarily mean that they're cured, right? Focusing on prevention of disease or disease progression. And then there are specific risk factors that can be identified and managed to help. And I hate the term prevent, because it gives the sense that we can absolutely stop these things. What we do is we impact the probability of risk. So risk reduction, really. And then, it's just fantastic that we have current medical and device therapies, and there's still so many coming down the pipe that have changed the natural history of heart failure. Just here, as we exit this slide, remember that we used to, and it's still actually a relevant statistic, is that 50% mortality in 5 years for heart failure. If you have a heart failure diagnosis, recognizing it's a heterogeneous term to say heart failure, 50% mortality in 5 years. That's just staggering. But we've made an impact on that, mainly in the past decade. Okay, so here are the stages of a heart failure. Stage A is those that are at risk for heart failure. And really, as I joked with AFib, it's like if you have a heart and you're alive, you're probably at risk for heart failure. But these are folks that do not have current symptoms or previous signs or symptoms. There's no structural or functional issues, but they do happen to have these risk factors: hypertension, they do have cardiovascular disease or diabetes, obesity, they've been exposed, to cardiotoxic agents, or maybe they have a genetic variant that's been found in their family for cardiomyopathy or personally. So they're at risk for heart failure. Here's stage B, so pre-heart failure. Now you've kind of moved forward without symptoms. So stage A and B are non-symptomatic. They haven't had an acute heart failure event. But stage B, you're having structural changes that are found either on echo or right heart cath, or biomarkers like natriuretic peptides. But I'm even having elevated BNP or NT-proBNP without symptoms. And then there are folks that have persistently elevated cardiac troponins. Something else is going on for those folks. But absent symptoms, they would still be stage B. Stage C is what we traditionally think of as heart failure. Please just throw away the term congestive heart failure. It's old. Just don't use it. Symptomatic heart failure makes a lot more sense. And here are folks that have current or have had previous symptoms. They've had a heart failure exacerbation, and now you're managing them because they have shown and proven that they will have, or potentially will have, another acute event where they become symptomatic. And so this stage makes up the majority of our patients here. Then as we fall into stage D, partly it's you've all seen that kind of, maybe you haven't, but the Kaplan-Meier curve that shows like this ongoing stage A, B, C, and D, where people bounce in and out of C until ultimately we might find them at the end of the road where they're a heart failure transplant, heart transplant or LVAD. But these are folks that have marked heart failure symptoms daily. And this is despite maximal therapy, rescue diuretics, etc. And they're having multiple hospitalizations. Now they're in that advanced heart failure group. And you and I should not be managing these folks. They should be going to heart failure, and preferably a little bit sooner. If they've had one of those kind of extended periods where they've had 1 or 2 hospitalizations, you might want to bring heart failure in on it early, because boy, it's a problem if they don't meet, they're not it's ironic, but they're not healthy enough for a transplant because we've waited too long. They've had some irreversible other organ effects. So we need to think about referring sooner. So here are the classification of heart failure again by stage, and this is this side. So we just talked about A, B, C, and D. But when we talk about New York Heart Association, they're two different things, right? Staging of heart failure versus its symptomatic class. And so, and that gets lost a lot when we talk about it. When I teach PA students about this, they get a little confused. And so here is where the NYHA really comes into play, because if you have symptoms, you're not stage B, that's pre-heart failure symptoms. You're not stage A, that's at risk for heart failure. It's really stage C. And of course, advanced stage D is I mean, these are folks that are NYHA class 4. They just cannot carry on any physical activity. They have symptoms at rest. They're not doing well. And can you move back and forth through these NYHA symptom stages? Yes. Yes. And that's the whole point of the symptoms, are that symptoms are modifiable. They go up and down depending on diuretics, depending on your therapies. But once they become symptomatic once, then they're in stage C. Okay. So here's a case study. Indira, a 72-year-old woman. So she, comes in, she reports an intermittent lower extremity swelling for the past 3 months. She's been experiencing increased shortness of breath over the past 10 days, and now really experiencing shortness of breath at rest. So it's no longer kind of this exertional. She now is experiencing it at rest. And then she received an albuterol inhaler at the Minute Clinic because they were like, oh, maybe this is reactive airway disease. That happens. And here, her past medical history is hypertension, hyperlipidemia, migraines. So she was already kind of an at-risk person with hypertension. And these were her therapies: lisinopril, atorvastatin, and sumatriptan. So the question that we pose to you is, we did an echo, and her EF is 35%. She's symptomatic. After diuresis, she's no longer experiencing symptoms of heart failure, even with physical activity. How would you classify her heart failure? Again, there's staging: at risk, at risk, at risk, pre, and then symptomatic, and then advanced, and then there's classifications of symptoms. And so, which do you think she's in? And I'm sorry, I didn't put these in letters. So I'll go ahead and give you the answer. So here she's stage C, right? She was at risk. She had hypertension. We didn't really know if she had any structural changes. So we skipped from A to C because now she's symptomatic. And anytime you've had one symptom, then you're in stage C. Here we did an echo and found that she does have some structural changes, and in fact has HFrEF, reduced ejection fraction. But we've diuresed her. So at one point, even though she was symptomatic exertion and then at rest, so her NYHA class leapt to 4, where she was symptomatic at rest, we diuresed her. She feels better. She's exercising. She's, even with this EF at 35%, so she's class 1. And so that's the rationale here. Again, we'll send out the slides, or I don't know why I'm using the royal we, but I'll send out the slides for you. Okay. So stage A, at-risk populations. Just kind of coming back to the staging here, now that we've looked at Indira, and she was hypertensive. So she was in stage A at one point. And 1 in 5 Americans over 40 will develop heart failure in their lifetime. This sounds a lot like AFib, right? Where it's kind of 1 in 4 after the age of 40. You'll notice that AFib is part of the risk for heart failure. So there's a lot of interdependency between these comorbid conditions that we should be thinking about. But I don't think this is any news to folks as to what's at risk. You might have not thought about it intentionally, but here, at least in list format, you can see the cardiovascular risk factors and then the non-cardiovascular. You'll see that renal dysfunction is key and top of list for folks developing heart failure. So managing those risks, treatment of stage A, here it's just, to reduce the risk of decline for that heart function. So you're just going to diagnose and treat you're trying to find those at-risk type of diagnoses and then manage and optimize those things. And then recognizing that there are other conditions and agents such as obesity, diabetes, tobacco use, etc., that can contribute to heart failure. So, we have to kind of think about that for each patient that comes through clinic. And I think if they're already being seen in a renal clinic, a nephrology clinic, they're at risk. And you'll be surprised at how many more heart failure folks that you've picked up that probably has not seen cardiology, is only seeing primary care, or maybe you've become their primary care provider, because that happens a lot for us in both of our specialties. Cardiovascular and nephrology is we end up being kind of holding the primary care portion. So pre-HF, this is the, on what you'll see here is the guidance. So level 1 is like, yes, everyone should do this. And then the level of evidence is really based on whether they're clinical trials or if it's consensus, or maybe there's 1 or 2 trials, but not a lot of trials in that space. And then certainly you don't want to be in the 3 side of things where you do something that causes harm. So here in the pre-HF, these are folks that have already shown that maybe they're at risk, but maybe they're stage B where there's structural problems, because EF 50%, then you really shouldn't be using those thiazolidinediones or pioglitazone and rosiglitazone. Let's just do that because that's easier. TZDs should not be used because they increase the risk of heart failure. So, again, why does that make sense? Well, we also see diabetic populations in cardiovascular and in our nephrology patients. So just recognize that we should not be using the TZDs in those patients. And then again, non-dihydropyridine calcium channel blockers, so verapamil and diltiazem. And we saw that in the other guidelines that we looked at for AFib, right? Don't use those calcium channel blockers. Amlodipine, fine. Felodipine, whatever, but it's the non-dihydropyridines that you don't use. And here then really, focus on ACE inhibitors, statins, for those that are intolerant to ACE, then ARBs. So it just makes sense, I think, for us with when we see patients that are pre-heart failure in stage A and B, we should be using these optimal therapies. Okay, so we're going to leap past that because that was stage A and B. Those were the guidelines for like how do you reduce risk for heart failure. Now they have symptoms. This is Indira. She's had an event, acute exacerbation with diuresed her. She has EF. In this case, it's HFrEF, but we'll talk about HFpEF as well because it's across the whole spectrum. But really, this is the alphabet soup of how we call these things. So you've got HFrEF. That's reduced EF, and then the mildly reduced EF, HFmrEF. Those are EFs of 41 to 49. Then, of course, the HFpEF group, where they've had heart failure exacerbation, but EF seems preserved. And then lastly, this group where they started out in HFrEF, you start GDMT or you treat some other underlying issue like thyroid toxicosis or AFib with RVR. And when you admitted them, you did a TEE or TTE, and their EF is reduced. Well, you treat the AFib RVR, or you treat the thyroid toxicosis, and they improve. Surprise, we actually don't know what to do with those folks. It's not that clear. But if they truly had a HFrEF from ischemic heart disease, or it's persistent HFrEF, and then you add GDMT and they improve, that's the group that we were, that I surveyed you on, and you should continue therapy even with an improved ejection fraction. So coming back to Indira, her symptoms are resolved with diuresis. She's now classified, as we said, stage C, because she's had an event, and then New York Heart Association class 1, because she's exercising now without any symptoms. And so you've decided to start her on GDMT for HFrEF. Which medications? What are those pillars of therapy? What is guideline-directed medical therapy for HFrEF? So let's kind of ask a question here. Which of the following medications will provide Indira mortality benefit for her HFrEF? So we're looking at atorvastatin, furosemide, omega-3 fatty acids, sacubitril, valsartan. And I'll go ahead and answer this, even though I'm as a quote lipidologist, I love statins. It's not that. It's sacubitril, because we're talking about HFrEF. In this case, the Paradigm HF trial. And man, I was there at the late breaker when this was reported. Everyone like stood up in the room, was clapping. I mean, it was like a standing ovation for a trial, because when you think of sacubitril valsartan, this was the first heart failure therapy in 10 years, new heart failure therapy, and it showed a mortality benefit. It was crazy. It was such a weird thing to be in the room while people stood and clapped there. So historical GDMT, this is how it built. So as we think of ACE-ARBs before ARNI, before sacubitril valsartan, we thought about 10 to 20% reduction mortality. Yes, the neurohormonal cascade, it improves that cardiac remodeling, but you have to think about what you're monitoring for. Beta blockers, same thing, HFrEF, 34% reduction in mortality. And then, your mineral corticoid receptor agonist, and this would be spironolactone or eplerenone. Now, what you haven't seen in here just yet is the non-steroidal MRA, so finerenone or Kerendia, but 30% reduction in mortality. So here are the first three pillars of guideline-directed medical therapy in HFrEF. But the new kids on the block end up being ARNI and SGLT2 inhibitor, right? So that we'll go through the data here, but these are the added portions to those pillars. And, you would say, well, isn't that 5 pillars? Well, ARNI is part of RAS, right? The renin-angiotensin aldosterone inhibition. And so if and when, wherever possible, if they have HFrEF and they're already on an ACE or an ARB, you really should move them to ARNI. The data from Paradigm HF, like I said, standing ovation, etc. Cost is an issue, prior authorization, etc. But where possible, if you're thinking about it and it's covered, ARNI, please do start sacubitril valsartan. But here are the main 4 pillars of GDMT, and taken together, the relative risk reduction is nearly 73%. 73% when you have all 4 therapies on board. And so we had Clyde Yancey, who's one of the foremost experts and is on both guidelines for HFpEF, HFrEF, all of this stuff. And what he showed, and let me take you back to the 50% mortality in 5 years. When you add all 4 of these pillars of therapy, you've doubled their lifespan. So 50% mortality in 5 years, now it pushes them to, I'm going the wrong way, 10 years, 50% in 10 years. So you've doubled the lifespan. Of course, people are still dying because it's a bad disease, but you've doubled their lifespan when you've placed them on the 4 pillars. And that's why I think it's so important for us to think about this. So here's the Paradigm HF study, reduction in cardiovascular death, heart failure hospitalizations. And you're like, well, those lines don't really split that far. And I will say it's very hard. It's when we do these trials, we're doing them as comparator trials, and you're trying to say, well, on top of already known therapy, what's the additive benefit of sacubitril valsartan on top, compared to enalapril by itself. And the thing that you need to remember is the DSMB, the Safety Monitoring Board, said you need to stop the trial. People are dying on enalapril more so than they are on sacubitril valsartan. So they did stop it. It was a 20% reduction in sudden death, cardiovascular death, in comparison between the 2 groups. And so here again, you'd say, well, do we have to worry about renal? Yeah, you do. But there was really low rates of discontinuation with this, even in the setting of renal impairment at the beginning. So there was more symptomatic hypotension, which should tell you that sacubitril valsartan is a really good antihypertensive. It's just not FDA indicated for that. They're currently in phase 3 trials to use this antihypertensive and get the indication for blood pressure lowering. But the indication it has is heart failure. So anyways, there you have it. Now, coming back to SGLT2. So we all use these. Hopefully you've had experience with them. But, this is HFrEF. And what you see is a reduction in heart failure, hospitalization, or cardiovascular death with SGLT2s. And so this first part is with diabetes. Remember, this SGLT2s, empagliflozin and dapagliflozin came out of a diabetes space, but we saw this strong signal because the FDA asked them, you need to show that it doesn't harm people in cardiovascular harm. And instead, we saw this great benefit. And so then they went forward in time with looking specifically at heart failure. And then later, they looked also at renal. So those are separate randomized clinical trials. And it's pretty cool to see that with diabetes, of course, it benefits people. Without diabetes, you don't have to have diabetes to use this. So I tell people it's not a diabetic drug. It's a cardiorenal drug that happens to impact diabetes. And that's what you need to switch is flip the script and recognize that these are cardiovascular renal drugs that happen to treat diabetes. So coming back to the TREAD-HF trial, this is the group that had an EF that was less than 40%, but then has an improvement. And what do we do? Well, TREAD-HF, they wanted to show this because it's one thing to kind of like, let's think about it, blah, blah, blah. But now we really need to decide, can we stop these medications? That was the hypothesis, is that you could stop the medications and it should be okay, because who wants to be on 4 meds that they don't need to be on, right? I mean, it was really thinking about the patient in this sense. These are folks that had EFs of less than 40, then improved to 50. And the question is do you have a relapse of dilated cardiomyopathy? And in a short time, within 6 months of stopping your therapies, well, the trial was stopped because of worsening EF. And so look at this. When we go to the next slide, the bottom line is these patients should continue their HFrEF treatment. But look at this. When you withdraw the treatment, look what happens. And the event rate here, okay, 10%, 20, 30, 40, 50, you had half of them by as early as 6 months that went back into a dilated cardiomyopathy if you stop their meds. What happens to the control group? Well, that's kind of funny. They do okay, even when their EF improves and you keep them on their therapy. So I think the TREAD-HF trial, if there's anything that you get out of this, is please recognize and reiterate with your patients that it's not like symptoms is like a cold where it's done, you don't have to do anything else. The symptoms are the manifestation of underlying disease. There is underlying disease. And even if the EF, which is just a number that we use, even if that improves, it doesn't change that they have this pathology. So TREAD-HF, hopefully you can see that it's no bueno when you stop your therapies for those patients. Okay, so according to the TREAD-HF trial, what should be done when a patient's LVEF improves from 35 to 50% while on GDMT? And I hope after that you come down to nothing. Do not do anything different. Continue the current therapy because when we remove therapy or withdraw therapy within 6 months, as early as 6 months, they have a return of, HFrEF is what happens, is their EF will reduce because that's what's propping up their improved EF is the therapies that you've deployed. Okay, what about HFmrEF? These are the folks that are in this mildly reduced EF, 41 to 49%. And really, it's reasonable to treat them like HFrEF. They don't have to be less than 40%. Now, the data is not as strong, but on the lower end where they're close to less than 40%, look, if you've looked at an echo report lately or recently or at all, we report them here as like, let's say 40% plus minus 3%, because there's some subjectivity. It depends on the echotech and how they line out the resting, the diastole and the systole, and when they chose diastole, when they chose systole, and then the reading cardiologist, as they're looking at me like, nah, I don't think so, and they change the way that it's calculated. Okay, so plus minus 3%. So 41 might as well be 38. I mean, I hope that's what you take away from this, is that in the lower range of HFrEF, when you see this, it's not like 41% is a magical number and that suddenly they don't have HFrEF. It's that they probably do have HFrEF, or at least statistically it's probable. So typically diuretics is, by the way, diuretics don't change mortality at all, period. They change quality of life and they help dig people out from volume overloaded. But there's no trial, randomized, observational, prospect, whatever, that show diuretics as uh, survival benefit. But from a symptomatic improvement, yes, and that's why it's a class 1. But SGLT2 inhibitors, I would argue they should be class 1. We'll see this happen probably in the near future, but they get a 2A. 2B is like, okay, yeah, we consider it. It's not as strong data, but so here's the RAS inhibitors. This is MRA, and then beta blockers. Really, this is kind of debatable, but in any case, they still fall within that HFrEF guideline. So here's HFpEF. What about if they're greater than or equal to 50%? And again, it looks very similar to HFmrEF, but you also should be treating any underlying contributing comorbidities, because this is a very heterogeneous group of people. You're just saying everyone has a normal LV function, but they're having these heart failure symptoms. So like, what the crap is going on? It can be obesity, it can be AFib, it can be hypertension or ischemic disease, it can be diastolic dysfunction, the stiff left atrium, and iron deficiency anemia. So there's all sorts of things that are leading to this heart failure exacerbation in HFpEF that is much wider and broader than when we say HFrEF. Because we can see functionally something with that heart that is reduced. Here in HFpEF, it's a little bit more difficult, which makes SGLT2s, the data, so much more astounding that we saw benefit in HFpEF with SGLT2s. And so honestly, that's to me, it makes this in contrast so much better for the SGLT2s as a therapy. Not as clear with the other therapies, though. I'm a fan of MRAs because of the TopCat study, and then SGLT2 inhibitors. And I think time will continue to bear out that I'm right on the MRAs. Okay, so here's HFpEF and SGLT2 inhibitors, Emperor Preserved and Deliver, which is dapagliflozin, and they're basically identical. So it's a class effect, honestly. I would say, at least in terms of empagliflozin and dapagliflozin. We don't know about canagliflozin and sotagliflozin. We do know, actually. That's SGLT1 and 2 inhibition. But you can see that it reduces risk by almost 21% of the primary endpoint. Just fantastic. And so here, use of SGLT2 inhibitors. How do we go about doing this? We just remember MODS. Okay, so this is just in heart failure in general: medication, activity, weight, diet, and then signs and symptoms. Or you can add smoking, so stop smoking, etc. But this is the way that folks are going to manage and implement SGLT2 inhibitors. So whether it's HFrEF or HFpEF, this is the simple part of using SGLT2 inhibitors in heart failure. It's good for all in terms of the entire spectrum of heart failure and ejection fraction. Okay, so in patients with an LVEF of 55%, and now HFpEF because they've had symptoms, they take furosemide at home. Which of the following would be the most appropriate agent to add to the patient's regimen? And hopefully now you'll kind of think with me that sacubitril/valsartan's 2B, losartan's 2B, isosorbide hydralazine is not on the list, and empagliflozin is 2A. So it is a 2A recommendation for HFpEF. Now what's the phrase? Not to be crude, but everybody's poop stinks. So SGLT2 inhibitors does have its set of adverse effects that you have to think about. So yes, I think of it as a miracle type of drug, but you have to be careful when you're starting these therapies. But the main things are, remember that part of SGLT2 inhibitors function is it works in multiple places. But from a diabetes standpoint, one of the things that they saw was that SGLT2 receptors reside in the bladder. And what they do is they allow for glucose reabsorption. So if you excrete glucose, I'm sorry, I said bladder, I meant kidney. If you excrete glucose in the kidney, then that receptor helps you to reabsorb it, right? So for someone that has diabetes and a glucose of 2, 3, 400, excreting it and not allowing it to come in is great. So that inhibition, the SGLT2 inhibitor, stops us from reabsorbing glucose. But in doing so, what happens? Well, osmosis and diffusion gradient, so more volume comes out. So you pee more. It's a mild diuretic. SGLT2s are mild diuretics, and you'll see a lowering of blood pressure. But the main thing here is now you're urinating a really high glucose yield volume of fluid. And so bacteria and fungus, et cetera, love that. And that's why UTIs are more prevalent, and then fungal infections are more prevalent in those that are taking SGLT2s. So it's just important to remember that. Now, canagliflozin's a funny one where the original Canvas trial, they saw amputations increase. That has not been seen since in multiple randomized trials afterwards. And we've not seen it in any of the other inhibitors. So I think that was a fluke. It was statistically significant in the Canvas trial, but it has not been proven out again. And remember that a p-value says, what are the chances that this is a fluke? So low chance when it's 0.05, we're like, oh, it's maybe a 5% chance that it's a fluke. Well, in this case, it was a fluke. So dapagliflozin, don't use it in active bladder cancer. And here, this side is important. Volume depletion. Hello, we're using this to save the kidney. And so can you have acute kidney injury? Yeah, you can. And typically what happens is GFR and creatinine will bump. GFR will lower and creatinine will bump in that first 1 to 2 months. This is not a reason to stop this drug. We know this happens. So just kind of hang in there with your patient and repeat, because in the end, the outcomes, the studies are with you, and the studies are with us pathophysiologically. That's just a weird thing that happens at the beginning of initiating SGLT2s. And I would argue that you probably shouldn't do a BMP or CMP at the very beginning if you're that worried. Just don't, because you're going to see these things happen. And if you wait long enough, meaning like 3, 4, 5 months, then that will normalize and actually probably improve. But euglycemic ketoacidosis is the other issue that tends to come out here. And for those that are not familiar, you don't see this huge glycemic jump, but still they have symptoms of ketoacidosis. And so this does happen when they're MPO, when the renal function in particular, and usually it's acute illness when they're on SGLT2. So when they're hospitalized with an acute illness, often the first thing hospitals will do will stop the SGLT2. Great. Prior to surgery, stop it. Yes, because you don't want to leave the person at risk. And then you just restart it afterwards, or before they get discharged. Okay. So initiating pharmacotherapy, same kind of thing here. We just have to think through our patients. Yes, it's complicated, and there's a lot of things that we're thinking through, but these are all the indications that you would think of SGLT2s and the 4 pillars of therapies. So just remember that folks with heart failure, 86% of them, a majority plus, have other chronic conditions that we're thinking about, and then just under half have like 5 or more comorbidities. So it's just, we have to be careful and think through it. Consequences of comorbidities, again, thinking through whatever they come with. Is this a reason? Is it an absolute contraindication? Is it relative? Does it just mean we should increase our screening as we initiate these therapies? And so, yes, all of that. And just make sure that you're thinking through, because again, SGLT2s, because they can lower volume, they can make people hypotensive. You can dry folks out if they're already on a diuretic and you add an SGLT2. So you just think through that. If you know the mechanisms, it's important. So I would say that most guidelines and most current clinical practice trials have shown that you can initiate all 4 of these therapies at the time that someone's hospitalized, just before they discharge. And actually, it's preferable to do it within 1 to 2 days. So you can actually watch them. If you're that worried, watch and see what happens as you initiate therapies. Then you can adjust before they discharge. Because imagine discharging someone on 4 new meds and like there's no one to catch them. You say 7 days, but maybe they don't make it, blah, 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 etc. So anyways, just think about that. And I would say if you haven't been initiating them in hospital, you really should consider it. And then watch how the course changes in the hospital for the good. Initiation, titration of GDMT. So again, this kind of speaks to this, the sequencing. There's no real good reason for the traditional sequencing of waiting and titrating, and adding things on a step. It leads to inertia. Someone else sees that patient. If you're sharing in a big practice, they don't know what you were thinking at the time that you were starting things. And so I've seen patients that have been left at low, I call them lickable doses. Mainly, it's like almost homeopathic. They started lisinopril 5 milligrams, and 10 years later, they're still, if they survive, they're on lisinopril 5 milligrams for no good reason. So just remember that, own it. Look at the patient chart, look at their meds, and own the titration. Be okay with that. So then, is it important? Yes. So as we think of each of these, remember, again, the relative risk of adding a beta blocker, it drops the risk of death by 25%. ARNIs drops the risk of death and hospitalization by 42%. MRAs, 37%. SGLT2s, nearly 60%. So there's clinical benefits of all these if they're started within 30 days. Or I'm sorry, let me say that oppositely. These are benefits that are seen within 30 days of initiation of any single one of these therapies. So initiate them, because really the clock starts as soon as the patient has the acute event. So this is STRONG HF. You really should go and look at this trial. It is just fantastic as a way of patient-centric care. So these are patients that were hospitalized, and then the question is what happens if we start these therapies soon and we intensify all the therapies quickly as possible. And you can see the usual care. It's just like this: step therapies. We might not titrate for several days, and this was 6 months out, but look at how quickly it separates. Within 30 days, you're already seeing a benefit, and it continues to widen. So if they followed these people longer, no doubt it would continue to separate out. And you'll see that by 6 months out on initiating all these therapies at high intensities, you've already made a significant reduction of 50% in death and heart failure hospitalizations. And then most of that was driven by heart failure hospitalization. So coming back to this, a 67-year-old patient with no past medical history, admitted for newly diagnosed HFrEF. Which of the following GDMT strategies will provide the greatest mortality benefit? And I'm just going to jump to it. All 4 GDMT agents at maximally tolerated doses, not max doses, but max tolerated doses. So they can be light doses to begin with, but get them on a lickable dose, and then that can be titrated as you go forward. But often what happens is it's just never started if someone doesn't get the initial therapy on board. Okay, so this was actually part of a CME that I gave as well. But after participating in this activity, blah, blah, blah. I mean, just think about this. I hope that you're more likely to think of the TREAD-HF trial. Do not stop people from therapies, because you recognize that it is an underlying pathophysiology. If they meet now they're normalized, quote unquote, normalized EF, they should remain on therapy. And then in terms of HFrEF and GDMT, hopefully you recognize that sooner is better. As we come back to this slide, rapid initiation, we see these benefits. It's not 90 days out. It's not 6 months out. It's not a year out. You see it as soon as 30 days as you initiate these therapies. And that's what the STRONG HF really sees, is that at 30 days already we see this split that occurs between the two groups. And of course, they reach statistical significance here, but from an observational standpoint and through multiple different trials, that's what we see as an early separation.